In this next section, we're going to talk about hypo and hypervolemia. For both hypo and hypervolemia, we're going to talk about general complaints that patients may have, what you're going to find on their physical exam, any vital sign abnormalities you want to look out for, or any laboratory values. This section is important because whenever we talk about the approach to the patients and supportive care, we need to know whether or not they need more fluids or if they need fluids off of them. Patients can present with the same disease state, but need totally different treatments based off of their hyper or hypovolemic status. So in hypovolemia, patients will complain of different things. One of the general complaints that they may have is fatigue or dizziness. Some patients may have muscle cramps. If you ever watch a sporting event, athletes typically will have these whenever they're dehydrated, and one of the reasons why is because they're hypovolemic at the time. And you can also see urine changes with either decreasing the amount of urine your body produces or decreasing the urine output, or having concentrated urine. This is part of the compensatory mechanism that our body often has whenever you know that whenever a patient has hypovolemic status, where your urine goes from its normal straw color to amber. And one of the reasons why is because our body is trying to hold on to all the excess of fluid that we can, and so it's going to try to draw that back into the body, and thus your urine's going to look a little bit different. As far as physical exam, you guys will notice that the patient may have poor skin turgor. As you can see, that's where this tinting remains after you've pinched the back of the hand. Poor capillary refill time. A picture of that's down here as well, where you press on that capillary, and then we see if the fluid has returned back to the nail bed by seeing whether or not the color returns after it's become white. Dry oral mucosas, sunken eyes, especially in children, and decreased tear production in babies. And then weight loss of greater than 3%. When we talk about vital signs, these patients typically are hypotensive with a resting tachycardia. Remember, in a hypovolemic state, your intervascular volume has been decreased. So, using the old, pump versus the hose, meaning that your heart's the pump and your vascular system is the hose. If you have less water in your vascular system, or less volume in that hose, in order to maintain adequate pressures, often your heart or the pump is going to have to increase its output. So that's why you'll see a resting tachycardia or an increased heart rate and hypotension. Patients may have weak pulses, especially in the extremities, and you can see orthostatic hypotension, where a patient goes from sitting to standing, and whenever they do this within 5 minutes, they have a decrease in systolic blood pressure of greater than 20 millimeters of mercury. One important laboratory value I guys want you to look for is the BUN to serum creatinine ratio of greater than 20 to 1. This is something I use almost every day on my service to determine whether or not somebody needs more fluids. This BUN to serum creatinine ratio is a great indicator for hypovolemic status as far as in laboratories. You will see other electrolyte abnormalities, but it's often dependent on what the etiology of your hypovolemia is in determining what kind of abnormalities of other electrolytes you'll see. You see a similar thing when we talk about hypervolemia. In hypervolemia, generally patients will complain of too much volume, of course, which usually manifests in shortness of breath, dyspnea on exertion, or bad breathing whenever you're moving. So those patients will often say, I'm short of breath whenever I try to do normal daily exercises or activities. Leg swelling, there's an example of that over here, or rapid weight gain. On physical exam, you'll see that the patient has peripheral edema. As you guys have already learned in your physical exam class, that peripheral edema can be measured between trace to +4. Anasarca, which really is just general edema or having extra fluid everywhere throughout the body. Pulmonary edema, which means there's extra fluid on the lungs, and this can usually manifest in rales or crackles whenever you're listening. And then ascites, which typically is extra edema in the gut area. This most frequently occurs in patients that have liver disease. Some of the causes of hypervolemia include CHF, which you guys are going to learn about, which is chronic heart failure in your cardio section. Renal diseases, which you guys obviously are going to learn about in this section, and then liver disease. Patients will complain of or have rapid weight gain in their vitals. They can be either hypertensive or hypotensive depending on the overall etiology and overall cardiac output. So it's really hard to tell whether or not the patient's going to be hypo or hypertensive. One important laboratory value I do want you guys to know is that they will have an increased BUN or B-type natriuretic peptide. So this is called a BNP. If you have an increased BNP, that could mean that you have a fluid overload status. So this is a really important one that I want you guys to remember, just like whenever I talked about BUN to serum creatinine ratios. Electrolyte disturbances, just like in the hypovolemia section, do vary widely depending on the overall etiology of the patient's hypervolemia.